Hi everyone, my name is Ariana, an occupational therapist here in Jackson. So I can get right into it because I only have 5 minutes. Occupational therapy is therapy that focuses on increasing a person's independence with their activities of daily living and instrumental activities of daily living, meaning getting dressed, going to the bathroom, showering, transferring into the shower safely, getting dressed, feeding yourself, and brushing your teeth. Mainly patients that come into inpatient rehab where I work have different deficits that can impact their independence with these daily activities. It could either be a stroke, a pedestrian hit by a car, brain injury, cancer, tumor. There's various diagnoses that we get here, and a lot of them are either very debilitated or can be hemiplegic, like a stroke patient. We educate them on compensatory strategy, adaptive strategies. We show them equipment that they can use to increase their independence and decrease burden of care. Physicians refer us for those reasons to target those things because people are not here very long in inpatient. They have very limited time. So we focus on those things. Other settings is outpatient. A lot of the times, therapists and outpatient treat people with orthopedic injuries or tendonitis or fractures, and they require splints or casts. So in that sense, a doctor would refer an OT in outpatient setting, or maybe they're a stroke that went home and now need outpatient services and require that additional therapy to get even more stronger. I'm gonna go on to the next thing they wanted me to talk about with you since I'm at 1 minute and 44 seconds. So 5 things that a physician should know. So 5 things is, number 1, OT's main base began with mental health. So we wear many hats. It's mental health where we began, and we've been around, our profession's been around for 100 years. Number 2 is, why does PT, OT, and speech sometimes look similar? Since OT, we focus on cognition, we also work on mobility like physical therapy. We are a little bit of everything, so we're overall we use a holistic approach. Number 3 are non-traditional roles. So non-traditional roles that OTs have are, we can be a mental health counselor, we can be a low vision specialist, we can work in hippotherapy, so therapy with horses. We can also be, what else? A lymphedema specialist. And I think that's one of the top ones I can think of that are very non-traditional outside of the hospital setting. 4th is physicians and referrals to OT. So a lot of the time physicians, when they put weight-bearing precautions or range of motion limitations, we want a lot of clarity to know what we have to do. A lot of the times they say non-weight bearing at all times. However, to brush your teeth or brush your hair, you need to pick up an item to do that. So at least be more clear about what kind of order you want. Can they do light ADOs or, those things like that? It will make a world of a difference. Number 5 is, something I would want you guys to know is, when you come and you're a resident, listen to your therapist. It's so important because we spend so much time with patients that it's, we always know what's going on with them. We know when they have pain. We know if they're vomiting, constant diarrhea. I mean, we spend 90 minutes 5-6 times a week with this patient. So please listen to the therapist. And then the last thing, what they want me to talk about with you is interprofessionalism. So very important. Respect everybody's opinion in any sort of team conference, in meetings. Listen to people, what they have to say. I think a lot of the times physicians, obviously you all know the medicine and we know the therapy, but sometimes we know when something's wrong, and it's important for you to listen. I mean, it's about the patient, not about us. And if we are not communicating well and understanding each other, it really can affect the patient and their safety going home. So final least thing I'm gonna say is just listen to each other's disciplines, respect everyone, and try to be a team player. Okay, it was very nice doing this video. I'm about to get to 5 minutes, so I'm gonna cut it. I hope you enjoyed watching me talk very quickly. Bye everyone.
Hi, my name is Winston Soto. I'm a physical therapist here at Jackson Memorial Hospital. I work primarily in the inpatient rehab setting. So inpatient rehab is a little bit different than other settings in that we get patients from acute care that aren't safe to go home, so they get admitted into inpatient rehabilitation, usually on average between 13 and 14 days, to try to get to a level where it's safe for them to go home. It can be through family training, just recovering overall to a level of independence, but most of the patients that do leave inpatient rehabilitation require some form of assistance when they go home. And physical therapy, along with all the other disciplines, we're involved in family training and in the patient's care throughout the entire process. Primarily, a patient would be referred to us if they're in the acute care setting and they're just overall unsafe to go home and they still need more time to recover. Two examples of patients that we might receive here would be a neurological patient like a CVA, maybe somebody with a right hemi, and they have significant weakness in the right upper extremity, right lower extremity, and as a result, they're requiring maximal assistance, 75% of the work from someone else to walk or to stand up from a chair or get to a bed and lay down. So they would have to come here to continue recovering. Another example could be a patient that was in a motor vehicle accident or a motorcycle accident and they're a multiple trauma. They could be post-surgical, have a hip fracture, a tib-fib fracture. They're unable to bear weight through the lower extremity, so they need to continue with therapy in an inpatient rehabilitation setting to learn how to use assistive devices appropriately, learn how to adhere to their weight-bearing precautions, and then, if necessary, train the family on how to assist them at home. So I'm going to go into some examples of some of the things that we've encountered in the past here in inpatient rehab that we wish some of the doctors might have known a little bit better or been more familiar with. One of the primary ones that I've seen in another setting, an outpatient, and sometimes here in inpatient, is an assumption that physical therapists only do massage or primarily perform massage on patients. So it'd be nice if physicians in the future would know that there's a little bit more, a lot more, I would say, that goes into our profession than just putting cream on a patient and rubbing them down or doing massage. Obviously, we get involved in mobility, getting people up, getting people moving, strengthening. So massage is an element of what we do, but it's very small part of what we do. Another one would be being clear with weight-bearing precautions or any sort of referral. What we've noticed, what we've seen a lot of here in inpatient rehab is there's not one language that's being spoken when it comes to weight-bearing precautions. Physicians have their own way of saying things. Some physicians will say toe down weight-bearing, others will say toe touch weight-bearing. So being very clear and having sort of one language that's being spoken so that the therapists know how to interpret the weight-bearing precaution. Also, just overall knowing the separation of disciplines. I know particularly with occupational therapy, there tends to be a lot of carryover between physical and occupational therapy. It helps when a physician is very knowledgeable in the differences between the professions when we're having certain conversations. Knowing that occupational therapy is more about what occupies your time, activities of daily living, more fine motor activities, whereas PT is more gross motor. And I think interprofessionalism is, in our setting, working with all the disciplines in collaboration is the most important thing that we do. And we do that on a daily basis. We have huddles in the afternoon every single day at our facility where we discuss the patient's progress. Nursing is involved, social work, OT, PT, speech therapy. And through collaboration between all the disciplines, we're always pushing discharge and we're providing the best possible care. So it is the most important thing that we do in this facility is collaborate between all the professions because everybody is helping the patient. And if we can all come together, ultimately we'll get the smoothest discharge.
Hi everyone, my name is Jocelyn Casas and I'm a speech and language pathologist here at Jackson Memorial Hospital. I've been a practicing medical SLP for the last 7 years. So I was asked a couple of questions which I'll be answering here today. And the first one was to describe the primary roles of my profession and the main reasons why a physician would refer his or her patient to my service. So as a medical SLP, my primary role is to evaluate and treat language, speech, cognition, voice, and swallowing impairments. In an acute inpatient rehabilitation setting, a physician would consult my services when their patient has suffered from, let's say, a traumatic brain injury or a stroke or a spinal cord injury or any other neurogenic disorder. We'd also be consulted with patients that have debility, post-transplants, or if they're part of the cancer rehab program. And we'd go into further assessment in terms of figuring out how has their language, their speech, their voice, their cognition, or their swallowing abilities been impacted. And so with language, we look at receptive and expressive language. So how well are they understanding language? How well are they expressing themselves? What are they saying? Is there meaning behind the context in which they are speaking? How is their speech? Okay, is it difficult to understand them, to comprehend them? Is it slurred? Are they confused and unaware of their general environment? How is their cognition? Are they able to orient? Can they recall information? Can they problem solve? Can they pay attention? Can they reason and or show awareness of themselves and their current situation? Okay, so that is the language and the cognitive linguistic component that we as speech and language pathologists assess. We look at vocal quality. How does their voice sound? How's their loudness? How's their intensity? Okay, are the vocal folds functioning adequately? If not, we consult, ENTs, and what could we as speech and language pathologists facilitate and implement with them to improve vocal fold closure, which will lead to better voice. We'd assess, with patients that have tracheostomies, we'd see if they're a candidate for a speaking valve, which is a one-way valve that allows air to enter through the upper airway and pass the vocal folds and produce speech, right? And then, of course, if they're experiencing any swallowing difficulties based on evaluation, we do, a lot of swallowing rehabilitation to reassess the swallow function or to improve the swallow function. Depending on their injury and the location of the injury in the brain, we may see a lot of different things, okay? For example, in case of language, if the person had a left CVA, our language is housed on the left side of our brain, and so we often see aphasia, which is a language impairment that hinders patients' abilities to understand information, to express themselves. Oftentimes after strokes, we have difficulty swallowing. We notice that patients are coughing, choking on their food. They may even have a hard time managing their own secretions. And so oftentimes in cases like this, we conduct an even more in-depth study called the Modified Barium Swallow Study. And with this, we go to radiology and we administer different types of consistencies mixed with a barium contrast that allows us to see through video x-ray how the food's going down, making sure that it's going in from the pharynx into the esophagus that leads to the stomach, and that there's good airway closure protecting the airway. Because if there's no good proper airway closure, a lot of escape can go into the airway that leads to the lungs, and this could lead to aspiration pneumonias. Okay, so we play a really, really big role in avoiding and preventing aspiration pneumonias and making sure that patients are on their least restrictive diets and their safest diet, I should say. After a swallow study, we make recommendations as appropriate, and we also are able to see what is wrong. Why are they having difficulty with swallowing? Is it because their swallow is delayed? Is it because they have decreased sensation or decreased pharyngeal strength? Is it because they have poor airway closure? Depending on what we see in those studies, we can then implement different techniques and exercises to improve these swallowing muscles. So it's a really, really complex process that I love to be a part of because it's incredible to see the progress these patients make in such a small amount of time. And so that is a lot of the reasons why a physician would refer us to go, consult us to go see a patient. They asked me to list and expand on up to 5 things that you wish more physicians, or that I wished more physicians knew about my specialty. So our title is extremely deceiving. We are speech and language pathologists, but we don't just focus on speech and language. Like I mentioned, we play a huge role in cognition, we play a huge role in voice, and we play a huge role in swallowing abilities. And we treat oral and pharyngeal dysphagia. However, once we go into an esophageal dysphagia, that's more of a GI consult.
Hi, my name is Karen Geronimo, and I'm a registered dietitian working at Jackson Memorial Hospital. And I want to say thank you for inviting me to join you for your workshop. So, my questions that I was asked to answer are to tell you about the primary roles of my profession. So, within my profession, those roles can be so varied, from working in management to clinical to research. But my role in particular is as part of the general medical team, the comprehensive team, and I would call myself the nutrition advocate for the patients. My basic role is to evaluate and assess patients' needs as they're based on their medical diagnosis, on their physical size, if they've lost weight, gained weight, their past medical history, their current nutritional status, and how it might have changed since they've been ill. And then using this information, I will make recommendations to the staff, to the doctors, to the nurses, to the therapists, and or to the patients or the families. When I assess a patient, I may involve the patient, the family members, or the caregivers. I might provide education that can help to optimize that patient's medical nutrition status. I might make recommendations that can help control disease progression and may contribute, of course, to the healing process of the body. So a couple of examples I can give you would be, for example, a physician might call on me or include me maybe when a patient has had a stroke and the speech therapist does an evaluation, speech evaluation, a swallow evaluation, and determines that that patient is having difficulty swallowing, at which time the patient may be changed to either not being able to eat or eating some type of a modified diet. If the patient is not able to eat, if they're made NPO, then I would determine a tube feeding that they could be put on, the type of formula and the rate of the formula that would help to meet their needs for that particular patient, of course taking into consideration what's going on with them medically and physically. Another time that a physician may call on me might be for education. For example, a person comes into the hospital with maybe a newly diagnosed case of diabetes, or they might have already had diabetes and just haven't been able to, or don't, they're choosing not to take care of themselves, at which time I would be consulted to meet with the patient, the family members, and or caregivers to help to educate them, to teach them how to control their blood sugar through their dietary choices. And during that time, I'll work with them and make it particular to their needs. So, as for what I would like physicians to know about my specialty, number one, I don't do any cooking in the hospital kitchen. I don't even hardly go in the kitchen. So I know that's a kind of funny thought, but I'm often asked about the foods in the kitchen or the choices, and I'm sorry, that's not my specialty at this time. Seriously though, I would like physicians to know that as a dietitian, I am available to share my base of knowledge and my experience to help them, to help you, to help our patients to heal, to recuperate, and that by providing optimal nutrition, whether it's by the mouth or by a tube feeding or by a vein, sometimes we'll use parenteral nutrition. This should be one of the priorities when a patient is hospitalized. So that's something I would like physicians to know, to take that into consideration. Over the years, I've seen many patients kept without eating, kept NPO for an extended period of time. And when they're kept this way without any food and they're already at risk, their health is already compromised, this can impact their healing and their recuperation process. And this is especially important these days when we're being told about the length of stay, and how can we control the length of stay. because that will impact the bottom line of the hospital. So if you're calling in the dietitian and using our services, that may help the patient to get healed and get out of the hospital a little bit faster and back to their life. And again, I'd like to emphasize that we're part of the team, and we're always available to help you, the physician, to figure out the best nutrition plan for your patient's needs.
I'm an LCSW, which is a licensed clinical social worker. So I'm a clinical social worker at the University of Miami Mailman Center for Child Development. What makes it stand out and is unique is that we look at the person in the environment. So it's more holistic approach to helping people with their problems, their issues. We look at family systems, we look at structural issues, environmental barriers. So it's always kind of been in the medical sphere of social work. So you work in hospitals, inpatient and outpatient. So what I've done now at the Mailman Center, and before I came to the Mailman Center, I work with children who are HIV positive in the Department of Pediatrics here at UM. And I loved it. It was one of the most rewarding jobs I've ever had. And I worked on a team. It was a team approach. So there were nurses, physicians, psychology was involved, and the social worker. So the social worker kind of was responsible for helping the children and the teenagers with adherence. If a child or a teen is struggling with their adherence to taking their medications, and also disclosing their diagnosis. So that often fell to the social worker. So anytime a child or a family is struggling with any kind of mental health issue or crisis situation, we also do referrals, concrete services, case management type work that maybe a psychologist wouldn't necessarily do, but social workers are really good at that as well. Any kind of mental health or psychosocial challenge, a social worker is ready to take on. So whether it be, let's say, a family is homeless or is experiencing domestic violence, or need some financial stability or help with finances, that we do that. So that would be a reason to refer to a social worker. And let's say a child or a family is sad or depressed, or they're going through some anxiety issues. That's a reason for a physician to refer to a social worker. So a social worker can do more of the concrete work of the referrals, but they also do clinical work. They do counseling and therapy to help the family. And we do work in groups. We also do group work in a cleft lip and palate clinic at the Mailman Center. So it's an interdisciplinary team. I was on the team. And when I would meet with the family, I would find out about their living situation, their social support system, that everybody else on the team didn't know about. So when we would report back after we all met with the family, there was a family that was, a mom was experiencing domestic violence. She opened up to me about it. She didn't open up to anybody else about it on the team. So we have a very holistic and broader sphere of how we view problems and concerns and challenges. One misconception that especially a social worker in the medical sphere, since that's kind of been my main area of focus, is that physicians don't seem to know or understand that social workers do therapy. They really associate social workers for concrete services. Oh, that you need help with your insurance, your Medicaid, your Medicare, refer to the social worker. We do so much more than that. So that's something I would really like to get across to everybody, that our training is very similar to psychologists. We may not have the PhD, but we are clinicians, we are therapists, we provide counseling services in addition to helping families find what they need, as far as food or homelessness or shelters. So that's a big misconception. Social workers are kind of known as the food stamp ladies or the food stamp workers, and that we do so much more than that. The other people on the team, audiology, speech pathology, nursing, I think we all have a role to play, and we all have our area of expertise, and we have to understand that with each other, and how that works, how we all work together and can help each other with the family to get the optimal care, the optimal services that they need. So the interprofessional team is crucial to that, to helping the family and the client or the patient get the services that they need and get the best care that they need.
I'm Dr. Winsome Thompson. I'm the attending psychologist for pediatric hematology oncology. I've been in that role for over 10 years, and that has involved frequent collaboration with other disciplines, physicians, social workers, nutritionists, physical therapy. It's a very interdisciplinary role, and I see children and young adults both on an outpatient basis in a clinic, and also on an inpatient basis at the Holtz Children's Hospital. I see my profession as a psychologist as addressing some aspects of the human being, of wellness, in the same way a cardiologist or a nephrologist or a pulmonologist would address the physical self. In psychology, we address the psychological and cognitive self. That's one way of putting it. All of these aspects of a human being contribute towards wellness. And given the continuing stigma about seeking mental health treatment, it's very important that other disciplines normalize and support it. And the perspective I like to use and to explain to my patients, it's as if you go and you seek care for all these other parts of your body, and your mind, where your thoughts and feelings come from, also needs care, just like any other part of your body. And thus a physician would refer someone with depressive or anxiety symptoms, somebody living with chronic pain, someone with learning disabilities. Those are some referral questions. Somebody having problems being totally engaged in the medical treatment plan. I wish physicians knew more about the words, the importance of the words that they choose, and their body language when interacting with patients, with families. They will share how much, how they're addressed, and if the physician seems interested in their unique experience, they will share how much that affects how they feel about the treatment and about coming back to see the physician. Another thing I'd like physicians to know is that it's very difficult for a psychologist, or a psychologist can rarely address a problem in 1 or 2 sessions. We need to build trust, and behavioral change is hard for any of us, or most of us. If we think about if we want to exercise or we want to change our diet, we want to start some new practice, think about how many attempts it takes most of us to do that. I think collaboration with physicians is a wonderful thing. The mind-body connection is really important, and if we look at it from the biopsychosocial perspective of wellness, looking at health promotion in that way, then spirituality, nutrition, physical health, mental health, learning about cultural values, all are intertwined, and I think it's important that we all have this perspective that the person who comes to us, all of those factors impinge upon them, and try to get to know the whole person that we're treating, these discrete aspects. May they be physical or psychological. The whole individual is who we should see as our patient. Thank you for listening, and I look forward to seeing some of you on the floors over the years.
Hello, my name is Dr. Robert Irwin. I'm a professor at the University of Miami, and I'm a physical medicine and rehabilitation doctor, which is also called a physiatrist. This specialty is known for its ability to work in a interprofessional manner. We work with physical therapists, occupational therapists, neuropsychologists, speech therapists, nursing, case management, as well as social workers and recreational therapists. What we're going to talk about today is when you might see someone in my practice taking care of a patient. In general, we look at function over everything else. So the whole idea of physical medicine and rehab is to get people back to as best of a function as they can after having a life-changing event. These kind of events can be things like a stroke, it could be a spinal cord injury after a skiing accident or a motor vehicle accident. We see a lot of diving accidents causing spinal cord injuries as well. It may also just be people who've had arthritis and then have had a joint replacement. They may have had a hip fracture. We also may see people with multiple fractures after car accidents. In addition to that, we're now seeing more patients who are surviving cancer treatments and having significant problems with functioning and get to learn how to use what they have left in order to continue to enjoy their life. The last groups that we may see are transplants. So this is another growing area where someone may have had a double lung transplant or a cardiac transplant. We may also see people with LVADs who then need to be re-educated on how to take care of themselves, how to deal with functioning with these different changes while they get back to their new normal. Now, what is the role that I have in taking care of patients? So I'm the person who would admit the patient to my team. So I'm the primary care physician. I coordinate all the care and I work with my therapist. I supposedly would lead the team. Now, leading the team does not mean I tell everybody what to do. I take their inputs and then I make decisions. On top of that, I need to make sure that our patients are healthy enough to be able to do their physical therapy and occupational therapy. So I need to make sure that there's no evidence of infections, that I treat the infections, that I do preventative things like trying to prevent deep venous thrombosis and pulmonary embolisms, try to keep their blood pressure under control so they don't have a repeat stroke perhaps, make sure that they don't have problems with their bowels and bladder. Spinal cord injuries may have autonomic dysreflexia as a result of urinary retention, and that can be a problem as they cannot function and it could actually be life-threatening. So these are the things that I need to do, is keep them well medically. I also need to keep their pain under control. If they've had a hip replacement, if they've had multiple fractures, we need to be able to keep these people moving. If it hurts too much to move, they won't get better. So my job is then to make sure that they can do that. Clearly, we do everything that a medical person would do if you were on the inpatient service, say internal medicine, but these people are less acute for the most part. Now, there are those who will have a PE, will have heart attacks while they're in rehab. And so I have to be able to be the one who can take care of that. I might need to run a code. I might need to be more aggressive with taking care to prevent these things or to get them over to a hospital if something needs to be done. Certainly you can have things like gallbladder problems, volvulus, and all that sort of stuff causing problems with their ability to be able to function. Now, how do I think that interprofessionalism affects the overall care in my specialty? Well, we live with interprofessionalism. Okay, if we didn't have a team of all the therapists and the case managers and everybody I mentioned before, then we would not be able to get these people together, because it is not one thing that gets someone home and gets them functioning, but it's the group of everybody. And our patients tell us that every time they go home, that we have a wonderful group of people who are able to take care of them. And this also is something that we can do to then train the family to be able to take their loved ones home and give them the care that they need. So I hope this video has been a little bit helpful in giving you an idea of what a physical medicine and rehabilitation doctor would do in the care of a patient in the interprofessional world. Thank you very much.